Good evening, colleagues, ladies and gentlemen. Welcome to this very interesting webinar on TB during the COVID-19 pandemic, strategies to minimize screening and testing. My name is Mergan Naidu. I'm the chair of the Education, Science and Technology Committee of SAMA and a director on the board. And it gives me great pleasure to introduce our esteemed panel of speakers today who will be talking on this topic. First up will be Prof. Salome Cherelambis, who will talk on minimizing the impact of COVID-19 on TB services. Professor Salome Cherelambis is the Deputy Scientific Officer at the Aurum Institute. She holds a medical degree from the University of Witwatersrand and an MSc and PhD in epidemiology at the London School of Hygiene and Tropical Medicine. She has vast experience in medical research in the fields of HIV and TB and has been involved in the HIV program implementation prior to the antiretroviral therapy rollout in the mining industry and was instrumental in the first large antiretroviral implementation project in the Anglo-American companies. Following that, Professor Salome was the main recipient of a large PEPFAR grant, which involved HIV program implementation in settings with private practitioners, public health hospitals, such as Chris Hani Baragwanath Hospital and Tembisa Hospital, and the Department of Correctional Services. As part of program implementation, she has also conducted research and published articles on TB-HIV integration, HIV program evaluations, and other topics related to HIV and TB. She is currently the principal investigator on a number of clinical trials and large cluster randomized epidemiological studies. You know, we're facing this triple pandemic, especially in low and middle income countries. And over the last 18 months, HIV and TB have taken a bit of a backseat to COVID-19. So TB comes, and TB has been highly neglected of late. And so I think it's very important that we refocus on this really big pandemic, which is still the leading cause of death in South Africa. So it gives me great pleasure to start with our first speaker, Prof. Salome Cherelambis. Please post all your questions in the Q&A session and not in the chat, and our panel of speakers will try to answer it either on the panel or at the end. Thank you very much.
Thank you, Professor Naidu. So I will be presenting on behalf of the National TB Think Tank, and I'll be talking about the South African post-COVID TB response as part of the TB working group that was established in April 2020 to try and deal with this problem of the neglected TB epidemic. So firstly, just to give us an understanding of what is going on with TB in our country, you'll see this slide that shows the TB incidence rates from 2000 to 2019. And you'll see that in 2010, around 2010 was when we reached our peak in TB incidence, and it has declined quite steadily since then, probably mostly because of the antiretroviral treatment rollout. You'll see also the bars show the TB incidence in HIV negative individuals in blue and in positive individuals in red. And you'll also see the deaths that are shown in the shaded areas. And you'll see that similar to the TB incidence, the deaths started to decline from 2011 onwards. And you'll see that there was a sharp decline in deaths due to the HIV treatment program and reduction in deaths in HIV positive individuals. But regardless of this, we still have one of the highest TB incidences in the world. And we have recently completed a TB prevalence survey. The survey results were presented at the beginning of this year, but the study actually took place in 2018. And what the prevalence survey showed us is that it confirmed the very, very high TB burden that we have in South Africa, one of the top TB burden countries in the world. estimating our prevalence to be around 852 per 100,000. And what the TB prevalence survey also showed us is that there is a large number of missing cases. So, if you compare the number of TB cases that were found in the prevalence survey versus the number of TB cases that are identified every year, we estimate that there are around 154,000 TB cases missed every year. And one of the reasons for that also became apparent through the prevalence survey. And what we saw was that this is just looking at all the TB cases that were identified in the survey. And you can see that a very large proportion of TB cases were identified through the X-ray program. And these cases, 58% of them did not have any symptoms of TB. So although we're using symptom screen to identify TB patients, we were able to determine from the survey that a large proportion of the TB patients would actually be missed on TB screen alone. So we really need to do a lot more to find the TB cases that are in our communities and are going undiagnosed. So what we do know is that all along the TB cascade, so just like in the HIV cascade, where you look at how many people are started on treatment, how many HIV cases there are and how many are identified, a similar process has taken place with TB, where we've looked at how many are the estimated number of cases that we have of TB in the country, and looked at the places in the TB cascade, whether it's accessing the TB test, being diagnosed with TB, and then finally being notified on treatment, and identified where in the TB cascade we are missing cases. And therefore, we are missing cases in all parts of the TB cascade, specifically people accessing TB testing and people who are tested being notified and diagnosed with TB being notified and started on TB treatment. So this is, this is looking at TB testing that has taken place at our national laboratories, and compared the TB testing in 2020 compared to what would have been expected, taking into account the previous 3 years. So the forecasted number of TB tests as well as the forecasted number of GeneXpert positive tests. And you can see the black line is indicating what actually happened in 2020. And the orange line is indicating what was forecasted to have happened. And you can see that there was a massive reduction in the number of TB tests. It's approximately 40% of the forecasted tests that should have taken place during this period from April 2020 to October 2020, and then started to recover after that, but still not reaching the optimal levels that you would have expected, especially since we would have missed a whole lot of TB tests during this period. And similarly with GeneXpert positives, we have, although not as massive a decline, but still a very big decline in the number of GeneXpert positive tests that were identified during this period. And we think this is mainly because individuals were not able to access facilities. The TB testing programs in the facilities also stopped with a focus on COVID. And so there is a massive need now to increase TB testing and to find the TB cases that were missed last year and to put everybody on treatment to avoid subsequent deaths and transmission. So the TB, the National Think Tank put together a TB response plan, and we have been working on the different aspects of the plan since April 2020, with a lot of difficulties in implementation because of the diverted interests, the diverted issues and resources that are taking place due to COVID-19. So firstly, just similarly looking at the different aspects of the TB cascade, starting off with screening. There is a self-screening app that has been put together that will allow people to screen for TB from the comfort of their own homes using their cell phones, whether it's through an app or through WhatsApp or through SMS. And then there's the use of looking at combined COVID and TB screening. And then also a lot of people, when the epidemic started, who were homeless, were placed in shelters. And this is also an opportunity where increased TB screening and HIV screening can take place. And so the SOP has been put together on shelter screening to increase that taking place whenever persons are placed into shelters. Then, and under testing for TB, we're looking at a new strategy called the TUT strategy, which Dr. Lebina will talk to a little bit more later on. We're also looking at rolling out digital chest X-ray that has been done in some facilities already and is showing some good results. And then increasing the use of LAMB testing, especially in the primary healthcare setting. It has been rolled out in hospitals, but a new guideline has come out to increase LAMB testing in primary healthcare settings. And we've also been looking at a public-private partnership where GPs could be enabled to test for TB in their practices using the public laboratory systems. And then on starting TB treatment, we're trying to reduce people who are lost to follow-up post-testing. And there's two initiatives that are being tried out there. One is SMSing directly the lab results to patients. That has been done with COVID and has been seen to be successful. And we're investigating how to do that for TB. And the other is the use of the national and the notifiable medical condition system to increase the number of people started on TB treatment, linking the laboratory systems to the health centers. And then finally, when people are started on treatment, to include TB treatment as well as TB preventive therapy in the chronic disease, medication disease dispensing program. And so all these initiatives really, they would include increased public communication, the training and education of health workers on these initiatives, and they need to be also partnered with monitoring and evaluation of all aspects of this program. So I'm just going to show you just some small, some snippets of some of these programs that I spoke about. We have, as I said, communication is a huge aspect. The National Minister did launch the TB Prevalence Survey and spoke about some of these activities. This needs to be continued with continued communication. We are working with the advocacy division within the TB program to increase TB awareness activities and awareness of some of these initiatives. There is continued discussion on dissemination of monthly TB testing volumes and making that available. And then the PEPFAR partners have all been briefed and have been included in this response. And there's been some discussion with SANEC also to improve communication around these issues. So just looking at some of the initiatives, the TB self-screening initiative, it's, as I said, it's an app, but also can also be used using SMS. And it works very much the same as the COVID self-screening app, where a person is also given a choice to screen for TB. And these are some of the results of the screening app. This is just early on when it started, but just indicating that it's a way of increasing to a large number of individuals screens with very little human resources needed to get this done. And this kind of indicating 14,000 screens with 133 positive tests. And this is possibly even an underestimate because individuals are expected to go back to the app and report that they had a positive test. But really indicating the power of something like this, where there's very little human interaction and a very large number of tests from the patient, from people who have gone through the screening process. This has improved over time. It's the most recent number was that around 32,000 had screened and around 250 had tested positive. So increasing people's use of this app would really help to identify more TB cases, people that need to come forward to test for TB. In addition, as I mentioned, there's been an initiative to combine COVID and TB screening, and this is just a bit from the TB and COVID screening guideline that has been disseminated to health facilities, where people have been given an indication of when someone should then also test for TB when they come forward for COVID testing. So a person who has had persistent cough for more than 2 weeks or has loss of weight or drenching night sweats should then also be tested for TB at the same time. And this is being rolled out in facilities, most of them also supported by the US partners. And then, as I mentioned, we also put together a guideline for TB testing at shelters. And then, another big initiative that Dr. Lebina will talk to in more detail is the targeted universal testing. And this is an initiative where instead of waiting for people to come forward with symptoms, we are now suggesting that all patients who have HIV, who have a TB contact and have prior TB that come into facilities are routinely tested for TB. So regardless of symptoms, the tests are done. As we've already said, that a large number of TB patients don't have symptoms. And this project was done recently that showed a very high yield of TB in people who have got these risk factors, 7.8% yield. And in the facilities that implemented this program, there was a 17% increase in TB cases with implementation of this program. So this is something that the department has taken upon to implement throughout the country, and new guidelines have been developed by the think tank and are currently being reviewed by the department and will be released quite soon on targeted universal testing. Another one of the initiatives that can increase TB testing is the implementation of LAM, as I've mentioned already, in facilities, and the guidelines for this have already been released. Training is underway, and this is expected to start throughout the country very soon. And as I've also mentioned, the way to reduce the initial loss to follow-up that we've been looking at is by increasing SMSing of expert results to patients, as well as the use of this NMC app for DSTB to support linkage to treatment. And both these programs are going to be piloted in the next couple of months in some of the districts and provinces to see if they do yield increased TB numbers. So just to say that similarly, we also have been looking at the preventive TB cascade and looking at initiatives to improve prevention of TB under personal protective equipment, looking at the use of face masks for all healthcare workers, under screening, looking at the use of healthcare workers to increase TB contact tracing as they have been used for COVID contact tracing. And then also to increase TB testing for healthcare workers, and also for the CCMDD program for preventive therapy, as well as for TB treatment. So I just want to acknowledge my colleagues at the TB Think Tank Secretariat, as well as the TB Response Task Team members, and the Bill and Melinda Gates Foundation that funds the TB Think Tank. Thank you.
Thank you, Prof. Salome. I've noticed that you've posted some questions. We'll take some of those questions in Q&A. Prof. Salome may actually answer some of the questions on the Q&A and post the response for the audience to view. Our next speaker is Dr. Libakatso Lebina, and she will be speaking on an introduction to systematic TB screening guidelines. Dr. Lebina is a director of the Perinatal HIV Research Unit at the University of Witwatersrand, managing multiple clinical trials as well as observational studies on HIV, TB, and COVID-19 prevention and treatment. She has recently graduated with a PhD in public health at the University of Cape Town, and this was based on assessing the implementation of integrated chronic disease management in primary healthcare clinics. She has co-authored over 50 publications in peer-reviewed scientific journals and presented at both local and international conferences. She's also an academic editor for PLOS ONE Scientific Journal. She has been a member of the TB Think Tank since 2018 and leading the Finding Missing TB Patients that Prof. Salome spoke about task team. The TB Think Tank is a multidisciplinary group that provides support to the South African National Department of Health TB program in bridging the gap between evidence and policy formulation. In her role in the TB Think Tank, she has worked on finding the missing TB patient strategy, the review of the LAM guidelines, as well as guidelines on systematic screening for TB. The think tank has also made recommendations for South Africa TB Services Recovery Plan in the time of COVID-19. She is also a member of the BRICS TB Research Network. Welcome, Dr. Lebina. Over to you.
Thank you very much for the invitation, and I hope you can hear me and see the slides. We'll be talking about systematic screening for TB. If I can just get confirmation that you can hear and you can see the slides, that would be great.
Yes, we can see them very clearly. Thank you, Dr. Lebina.
Thank you. So I'll talk, of course, about the missing TB patients and the recently released World Health Organization guidelines on systematic screening for TB, as well as what the TB think tank has presented to the Department of Health as a recommendation on how TB screening should be done to increase the diagnosis or case finding, especially in the time of COVID. The End TB strategy and the United Nations high-level meeting had set these big targets of treating about 40 million people with TB between 2018 to 2020. Although about half that time has elapsed, only 35% of this target has been achieved. And based on the calculated global TB incidence of about 10 million people in 2019, unfortunately, only 7.1 million of those people were started on TB treatment. And on the right, as you can see, about 6 million people were started on TB treatment in 2015, and that number has only increased to 7.1 million over the years. So we're starting more people on TB treatment, but is still lower than the estimated TB incidence. About a third of people with TB are neither diagnosed nor started on TB treatment. And this Dr. Salome has already talked about, and during the missing TB patients, the biggest gaps are in 1, 2, and 3, in that some people are not able to access diagnostic tests. Some people access the test or present to the clinic, but are either misdiagnosed or not investigated for TB. And some people, even though they've been investigated or some even started on TB treatment, they are not captured or registered in the right documents for them to be recognized as notified TB cases. And in South Africa, we have an estimated 30 to 47 people, 37 people with TB that are neither diagnosed nor started on TB treatment, as those are the estimates that have also been shared, that in about 2019, we think about 160,000 of TB cases were neither diagnosed or started on TB treatment or notified. And that's the big gap that we've been trying to address. And I thought maybe just to share from some other countries as well how the data looks like. On the left is a TB care cascade from India that shows that 72% of the people that are estimated to be having with TB reach TB diagnostic centers for investigation. But overall, 47% of people with TB are neither diagnosed nor started on TB treatment. And on the right, we have a TB treatment cascade for drug-resistant TB in Nigeria, and only 3.5% of patients that are estimated to be having drug-resistant TB are started on treatment according to their records. So there's even a bigger gap in terms of missing TB patients. And we'll then be looking at what has the World Health Organization recommended to be done in such settings to increase TB diagnosis. And just as a definition, the systematic screening for TB includes sort of a systematic way of identifying people who could have TB, even though they are not presenting with symptoms or will be easily picked up by the health system. It's more of an active approach by the health system to find patients with TB. It has become even more compelling that active case finding is done by many health systems in order to achieve the end TB targets. And the screening and testing for TB that relies on patients to present to the health facility with symptoms is definitely not ideal. For some people are asymptomatic. We need health systems that are initiating TB screening in the health facilities and in the communities that targets people at risk, those that have been exposed, those that are infected, irrespective of their symptoms. The screening process should be aiming to reach most with very little decision making at the implementers level. So the simpler the screening guidelines, the most likely they will be implemented with high fidelity. And according to the guidelines released by WHO, this is a list of people that should be considered to be at high risk of TB. General population, if a TB prevalence is about 0.5% or higher. And in South Africa, we now, as shown by the TB prevalence, we're at about 8.5 to 9% if you round it off, TB prevalence. So we definitely qualify to do systematic screening in the general population. This should also, although in some provinces in South Africa, the TB prevalence is slightly lower, but I think overall, we do understand that our prevalence is high. One of the factors that has fueled TB is the HIV epidemic, especially in sub-Saharan Africa. So people living with HIV are also at very high risk and should be screened for TB at every visit to a health facility. Household contacts and other close contacts of TB index cases, prisoners, and current and former workers in workplaces with exposure to silica. Those could be mines or quarries. The recommended tools for systematic screening for TB include the symptom screen, followed by other investigations for those that have symptoms. That's the 4 symptom screen that we all know about, have been trained with, but we also know that it will then miss cases in some instances, especially for people living with HIV, pregnant women, especially also if they are HIV infected, children, and also the implementation has not been to the highest fidelity in the clinics. Somehow, if you say to the nurse you are fine, it's also assumed you do not have any of the 4 classical TB symptoms. Chest X-ray, molecular diagnostic tests like XPECT and C-reactive protein have also been recommended as some of the additional tools that can be used for TB screening. And the diagnostic accuracy of each of the tools varies, with some X-ray having sort of the highest specificity and sensitivity compared to all the others. So if you look at the first recommendation will be chest X-ray followed by molecular diagnostic tests and then TB symptom screen. However, for chest X-ray to be considered as a screening tool, it has to be rapid, it has to be postable, the results have to be available immediately. You cannot be requiring a radiologist to review and interpret the findings. That's where the digital chest X-rays and reports become more appropriate. However, the challenge is that it requires a large capital investment. in purchasing that equipment, as well as budget allowance to cover the recurrent costs of maintaining it. Radiation safety has not been a major concern, as the newer innovations have less radiation exposure. The diagnostic molecular tools that we have in South Africa is the GeneXpert, which has been placed in many laboratories across the countries in South Africa. And the advantage is that it provides that rapid result within 2 hours, and it's also automated, and the results are then easy to interpret. It's almost like a yes or no. And this debate is still ongoing as to whether these expert machines should be centralized in the laboratories as they are currently, and the results received the next day at the clinic or by the next visit for the patient, or the expert should actually be placed in the clinics to reduce the initial loss to follow up for the patients. And these recently published systematic screening guidelines by the World Health Organization have provided up to 27 screening algorithms for various populations, 10 options for the general population, 11 for people living with HIV, and 6 for children. The major difference with each algorithm is the first tool used for screening or the point of entry. For example, some algorithms' first screening tool is the WHO 4-symptom screen, while others use chest X-ray, and others would be a combination of those, either sequentially or in parallel. And deciding which algorithm to follow will then have to be that difficult decision for each health system to say what is suitable for our context. And that decision is usually guided by the objectives of the screening, the profile of the population that needs to be screened, like HIV prevalence, TB prevalence, and the cost and the availability of the recommended tools. In this slide, we're looking at the comparative assessment of the algorithms. One of the ones that is shown to have a higher yield is when a digital chest X-ray is provided to all clinic attendees to screen for TB, and further investigations are done to those who screen positive on chest X-ray. So that will it is estimated that with such a general approach, 80% of TB cases or more will be detected if TB prevalence in the population is about 1%. And let me go back again. Based on these algorithms, so algorithm 6, 8, 2, and 4 are the ones that then sort of have the highest yield, and they are all relying on chest X-ray and the symptom screen. And this is this is algorithm 8 and algorithm 6 in more detail. Algorithm 6 is the symptom screen, and then followed by chest X-ray if you need screen negative. However, for those that screen positive, they're immediately then referred for more investigation with the expert or similar tests. And then for algorithm 6, it's sort of a parallel assessment, and you get either or. There's no really any decision about who goes to the left or to the right, and anyone who screens positive on any tool, then it's investigated further for TB. When comparing the various algorithms for people living with HIV, algorithm 7 and 9 have the highest yield, as they both pick up about 65% of cases. Both algorithms also include a chest X-ray and the 4-symptom screen. Algorithm 2 and 4 use CRP and molecular diagnostic tool, and estimate to diagnose about 31 to 15% of prevalent cases. And a single screen, which is algorithm 11, with the molecular diagnostic tool like Expert, diagnoses about 45% of prevalent cases. However, that detection changes if the screening is being done in patients that have been admitted in medical wards, and if you use an expert or similar to screen for TB in such a population, proportion of prevalent cases detected can increase up to 77%. And this is some of the algorithms recommended for children living with HIV less than 10 years, which is a TB symptom screen, and followed by diagnostic investigation. However, we know this is particularly problematic in children, as symptoms and specimens for investigations are more difficult to ascertain. And this is the study that Dr. Salome also summarized that we presented at CROI in March 2021. Where clinic attendees were investigated for TB with expert or culture if they were considered to be at high risk for TB. And overall, 6% were found to be positive for TB. We screened over 30,000 people in intervention clinics. And the high-risk patients included in the study were those that are HIV infected or had a previous TB in the last 2 years, or contacts of TB index cases in the last year. In the clinics, on the table on the left, in the clinics that were control clinics where the intervention of universal or systematic screening with expert was not implemented. The number of TB cases diagnosed per month per clinic reduced to 1.5 cases per month. Whereas in the intervention clinics where the systematic screening was implemented, there was an increase of an average of 1.2 cases per clinic per month that was diagnosed in those clinics. And with those results and what has been presented as the new guidelines by the World Health Organization, one may wonder what are the plans for South Africa when it comes to systematic screening. This is a strategy that was developed prior to COVID-19, about 2018-19, on how we can find the missing TB patients in South Africa. And one of the things that was included in that strategy was optimizing TB screening, as well as contact tracing, revising the guidelines to enhance diagnostic yield, and improving the data collection processes so that all those that are diagnosed are captured appropriately and our notification rates can be more accurate. However, despite these best laid out plans, we have had major changes with the COVID-19 pandemic. As we had our first case in South Africa in about March 2020, life has never been the same. COVID and TB are a dangerous combination for various reasons, including diagnosis, management, and long-term clinical outcomes. However, we could also apply some of the strategies on finding TB to COVID and vice versa, such as contact tracing and access to services for those at high risk. At the same time, the COVID-associated restrictions and socioeconomic factors have also resulted in reduced utilization of health services and fewer people being tested for TB, as well as affecting supply chain management and increased stockouts of medication in facilities. So we need, as we plan, we also need to think of how we can counter those effects. We reviewed TB diagnosis in Rahima Musa and Chris Hani Baragwanath Hospital here in Johannesburg, and there were fewer TB cases being diagnosed, although the TB prevalence per 1,000 admissions did not change much. For example, at Chris Hani, the median TB cases diagnosed per month was 25 TB cases pre-lockdown, and this reduced to 11 TB cases after the COVID pandemic. Yet the TB prevalence per 1,000 admissions was 28 and 23, which did not change much. And this data has also been shown that the South African NICD has also reported fewer tests of experts being done compared to the forecast that was calculated with data from previous periods. As a result, less TB cases were diagnosed overall, and also fewer drug-resistant TB cases. However, the proportion of positive expert samples was higher than the estimated projections. And I think, yeah, it's been covered. Both TB and COVID are respiratory illnesses, and therefore they will have similar symptoms such as fever, cough, and fatigue. And an integrated approach to screening and diagnosis for these two conditions will definitely minimize misdiagnosis or missed cases. Contact tracing team that goes out to be screening for COVID should also be screening for TB as well. And innovative diagnostics are required so that one sample could be utilized for both TB and COVID testing. Some of the molecular diagnostic tools like NHLS could also have cartridges that can do both TB and COVID testing, but modifications to the lab processes will need to be done to allow for that to happen. So if we can have one sample that could be tested for all, that would be ideal. A team at the NHLS and Leslie Scott and Kamba is the one who wrote the abstract, has also shown that a swab capture can be used to diagnose both TB and expert on one sample. And on data shared by NICD, they've shown that amongst 6,800 patients that were tested for TB and COVID, 80 or 1% of them were positive for both COVID and TB. And these co-infected patients represented about 8% of the 1,065 patients that were diagnosed with COVID. So the co-infection, COVID and TB, should also be concerned as part of screening. These are the guidelines that have been presented for review by the South African Department of Health, that were done by the TB think tank. See, my time is up. And it shows the recommendation is that all adults or children presenting to the healthcare facilities should be screened for TB if they are considered to be at high risk, or if they have any of the classical symptoms for TB. And of course, either using NHLS or chest X-ray if it's available, or LAM for those that are HIV infected. And I think, yeah, thank you very much for your time, and I'll be looking in the chat for the questions. Thanks.
Thank you, Dr. Lebina. That was a very interesting presentation. And with regards to the missing TB patients, Dr. Mhlaba, Solofelo Mhlaba, is the one who's going to give us some solutions. Because these missing patients represent reservoirs in the community, and we are unlikely to overcome the burden of TB if we don't get rid of the reservoirs. Dr. Mhlaba is a public health specialist and lecturer in the discipline of public health medicine at the University of KwaZulu-Natal in Durban. She has worked as a TB and HIV specialist in South Africa's public sector. She is also co-PI of the TB Reach funded Connect TB study, which links symptomatic patients of private GPs in eThekwini to free TB testing through the NHLS. And she will provide an overview of the Connect TB study. Thank you, Dr. Mhlaba.
Thank you, Prof, for the opportunity. My name is Solofelo Mhlaba, and together with Dr. Jody Boffa, are the PIs in the study. So this study is funded, as Prof said, through the Stop TB Partnership, and is a TB Reach grant. So it's aimed to fast track an intervention that seeks to reduce diagnostic and treatment delays at all steps of the TB cascade, as has been discussed. So one strength of this study is that we have a multidisciplinary team, which I will just show on the slide here, which is one of the, one of the benefits of this study is that we have a multidisciplinary team. So in terms of a background for this study, just to give a background, this study was motivated by previous studies which have been done, which found that nearly half of people with TB don't make it through the TB cascade. This next study in particular was conducted among members of our team and found that more than half of private GPs in Durban and Cape Town who received mystery patients with textbook symptoms didn't send patients for TB tests, whether it's private or public. So in follow-up interviews and surveys, many saw access to convenient and low-cost testing influencing the TB testing, and that was a barrier. So it is therefore important as per National Strategic Plan that we promote partnership, collaboration, cooperation, and shared accountability among government structures, civil society, development partners, and private sector organizations. So in terms of the methods, this study, the study design is an intervention at population level, currently being conducted in eThekwini district as the evaluation population receiving the intervention, and Umgungundlovu and Cape Town districts as control populations. And the study population are the consenting private GPs in eThekwini. This slide gives a summary of the study process, intervention process. If we follow the picks in an anti-clockwise fashion, at the top is a smartphone. So GPs are offered quick and convenient trainings, firstly on the use of the Vula smartphone application, and then on-site sputum specimen collection training. They also get the study's diagnostic and management algorithm. So the GP logs on Vula, they collect the sputum jars and the resources are provided for. These sputum jars are then collected from GPs and transported with transport provided to the NHLS laboratory that's in Albert Lutuli. Patients are thus connected to free TB testing to the public sector lab for GeneXpert testing and follow-up TB testing. GPs are then notified of the results and instructed on the next steps on Vula. And patients are prompted by SMS for the results. In terms of the TB notification, these patients, we do notification for the GPs. And also to mention that people who are diagnosed with TB also receive telephonic adherence support provided by our adherence facilitators who actually monitor patient treatment journeys and troubleshoot any barriers to adherence. This slide is a screenshot of the Vula app platform. So GPs are asked to fill in a basic form on Vula, which once sent initiates a process for our drivers to pick up the sample. So in particular, GPs are asked where the patient would like to be treated, and if positive, they obtain the current HIV status, both of which help the management steps when the results come back. So patients might opt to go to public or stick with the private sector with the GPs. So for an example, one of the interesting things that we have begun to do is to split all sputum samples that have been received so that we can initiate the appropriate follow-up tests according to NTP guidelines without the patient having to return to the practice for a second sample. The chat function in VULA enables the study team to report TB test results securely to the GP in real time, along with the next management steps. The ability to chat back and forth with the GP allows clarification on any questions they may have. So in terms of the outcome for the study, we will be comparing quarterly district level TB notifications with previous years. We'll compare the notifications to the control districts. And then secondary outcomes, we look at the average time between the first test and treatment initiation, study versus district, average time to treatment completion, study versus district-wide data, and a diagnostic yield. So if there's a marked increase in TB notification numbers against the control populations, and we can prove that this works, the findings can be used to leverage global funds for scale-up, but the TB reach would have to get DOH approval for that to happen. The department is actually very keen to receive the results of the study. That is why we really wish to get colleagues here on board on the study for the purpose. And we also wish to acknowledge here the KZN Department of Health, who is involved in the study, and they're actually funding the sputum cups and the GeneXpert testing for our patients. This slide is basically our screening, testing, and management algorithm, which slightly varies from the national guidelines. So when a patient comes in with symptoms that we have mentioned there, cough for more than 2 weeks in HIV negative patient, cough of any duration in HIV positive patient, cough and night sweats of any duration, cough and weight loss, any duration. What we do is that obviously that's a suspect and would be eligible for the study, though we do encourage that doctors initiate testing whenever they have a high index of suspicion. And as mentioned before, sometimes TB symptoms can overlap with COVID, so we encourage to send both tests if unsure. Now, this data, this graph just shows, what has been, since the intervention started, how things have been by week. So the study began in May with 78 GPs recruited and 26 trained on VULA. As you can see by the blue line, the number of specimen requests has been slowly climbing, and the number of GPs participating has increased on the gray line. The bars show the yield by week. Week 8 and 9 corresponded to level 4 lockdown. Doctors were still submitting high numbers of samples, but for the first time we had 0 positive tests. And at the time, that's where we were seeing the beginning of a rise of COVID third wave. And then if you look at the week 11 also, unfortunately, we had no samples because of that, the upheaval here in KZN. So in terms of the early results, we've got 17 of 92 specimens who have tested positive for drug-susceptible TB with a diagnostic yield of 18.5%. 7 of 17 people with TB also have HIV. 40% of specimens submitted were among people living with HIV, and all 17 people with TB currently receiving adherence support. And the adherence facilitators have really been able to connect patients to treatment despite the upheaval we faced. Now, in terms of the challenges, just to say that, during recruitment, some GPs were afraid to collect sputum on site, at their practices due to COVID. We do encourage GPs to ask patients to provide samples outside. We initially offered CPD accredited webinars to train GPs on VULA and sputum collection, but only the most keen GPs attended. Maybe we were asking too much from the GPs, but what we've done is we've moved now to offering shorter on-site training at the time of recruitment. But now, because of the third wave, it has prevented, the in-person visits for now. So we now have a short video link that GPs can watch, and but of course, the recent events have meant that we've received, things have been slowing down. We have received 0 requests as we speak now in the past week. Also to mention that, many of our GP practices have been affected by violence. So those are the issues that we're still grappling with. But the Connect TB staff, they're doing whatever they can to get the doctors back on their feet. We have an account here, and we'd like to encourage donations to help GPs rebuild their practices. All funds will go directly to the affected GPs in eThekwini. Please feel free to take a screenshot of the details. And in terms of the next step to overcome some of the challenges, we will be expanding the study to include private specialists in eThekwini. So if you are interested in participation, would really appreciate if you can contact us. We'll put the details at the end. And we're also proposing to have a standardized patient component to evaluate improvement in TB management in the private sector as a result of this intervention. And we also aim to onboard the TB clinics on VULA to have a direct communication between clinics and GPs. So we actually, in conclusion, would like to acknowledge and thank all these partners without which this study would not be successful. Thank you.
Thank you, Sholo. Thank you for the presentation. So we have a few minutes remaining, and I'm going to try to look at some of the questions that has been posted in the Q&A. Right, so let's look at some of the questions. Some of them have been, how do you access the app that Prof. Salome, you want to just respond to that?
Yes, thanks. I struggled to actually respond to that because I pressed the wrong buttons. But let me just try and find the link to the app. Sorry, it was here just now. Let me just see. So I'm just going to share my screen. So this is do you say hi to this number? And that puts you through to that.
Okay, thank you very much.
There is supposed to be a way that you can access it on SMS, and I'm not able to find it right now. If I do find it, I will send it to this group.
Okay, so let's just look at the other questions. I think you answered most of the questions. How do you, okay, that was how, the first national TB prevalence survey. I think there was just a short report that was provided. How is the GeneXpert Ultra being interpreted in patients with previous TB?
Yeah, so maybe I can answer that. If a patient has had previous TB and they test positive on GeneXpert, we know that it can be a false positive. As a molecular diagnostic tool, it picks up DNA. It doesn't say whether it's old or new or alive. And the best is to confirm the diagnosis with a culture. Thanks.
Then, okay, so that's the other questions. I think we've answered most of the other questions. Am I missing any that haven't been answered?
Yeah, and the link for accessing the TB report was also provided by Dr. Moyo. For those that have missed it, it's there in the chat Q&A box. Thanks.
Do you think that the use of face masks for the COVID-19 pandemic has in any way influenced the incidence of TB, either positively or negatively? I think anybody can answer this.
Well, I think that being an eternal optimist, I'm hoping that that is the case, that face masks have possibly, or not only face masks, but also isolation and all the social distancing that we've been doing may have reduced TB incidence, but we won't know for a little while. So at the moment, we think that most of the reduction in TB cases is due to people not coming forward and not being tested. But there is a possibility that this social distancing may have reduced incidence and transmission. What we are very happy about is the fact that it was so difficult to even get TB nurses to put on face masks when they were seeing TB patients. And now every grocery worker, every person in the street has had to wear a face mask. And we are hoping that that will lead to an increased use of face masks going forward, and possibly even the use of N95 face masks for all health workers going forward. So there is a position paper that is being put together at the moment. It will be backed by the TB think tank as well, where we would be trying to make the case that all health workers should wear N95 masks at all times to prevent them from getting TB.
Okay, thank you. We've just got two last questions. Is the Vula app used only for experimental purposes, or, as I can't find a link related to TB? Yes, at the moment, I think the one specific to TB is being used entirely for the study, but it may become available more widely after the study. Solo, you want to comment?
Yes, sure. I agree with what you said. Okay.
And then, is there a portal link for online TB case reporting? Yes, there is. Who would like to take that question? Dr. Lebina? Okay, so there is the NMC app, Notifiable Medical Conditions app, that you can register with the NICD. You can register as a user, and you can notify COVID-19, you could notify TB, any of the notifiable conditions, including maternal deaths, including poisonings from environmental poisons, etc. So we would strongly encourage clinicians to use the NMC app. You can download it, or you could use it in the desktop format. I think Prof. Salome mentioned it in her talk. Prof. Salome?
Yes, thanks, Prof. Naidu. Yes, there is the NMC app, and we'd encourage everyone to use it. And it would be nice to hear from the medical colleagues about testing for TB. We have been trying to get the department to see if they could open up testing for TB in private practices, a way of getting, because we know that in private, TB testing is extremely expensive and it's difficult to do, with private patients. But, if private practitioners were able to offer the TB test through the national laboratory systems, that would be something that would be very much, I think that it would make a very big difference to finding TB in the country. And one of the concerns that the department has is that general practitioners would require some kind of incentive to do this. And, I think the argument that some of us are making is that the fact that you would be able to diagnose TB in your patient is incentive enough. So as just as a plea to Soma, to see if that is something that you would want to see, and whether there's a way of taking that discussion forward and seeing if there is a possibility for, ability for all private practitioners to be able to request a TB test at the National Health Laboratory Services. That would really make a big difference, I think.
So certainly it's something that Sama can actually take up, and certainly I will inquire on that. Okay, I think we've come to the end of our slot. Thank you everybody for participating, and thank you to our speakers for kindly offering their time to be involved in this webinar. I hope everybody has gained a lot in terms of TB diagnostics and screening and the effect of COVID-19 on the TB pandemic. Just to remind you that our conference is going to be occurring shortly. It's virtual. It's in short, manageable slots of 4 hours. And the theme is practicing during the pandemic. We have an excellent lineup of speakers. So please register for the conference. It occurs at times that's convenient for all members, for all healthcare workers. So with that, I would like to say thank you and good night to everybody. Bye.
Bye-bye. Thanks, everyone.
Thank you, everyone.